Hi, good day to everyone. I'm Geraldine from Taiwan. First of all, I would like to thank the Academy for giving this great opportunity for me to share this lecture with the Academy members. The topic today I would like to talk about is about aesthetic reconstruction in implant dentistry. Basically, it's from single implant to compromise maxillary anterior dentition. I'm a part-time faculty at Harvard School of Dental Medicine and also an assistant professor at Taipei Medical University. I'm located in Taiwan. I have my own clinic, dental practice, and teaching institute, and also I'm also running a dental laboratory for the dental works. So regarding the lectures today, we're talking about the aesthetics, and I would also talk about how to reconstruct the implants in the aesthetic zone and also in a aesthetic way, and how to do those cases from surgically all the way toward prosthetically. So to begin with, I would like to talk about the aesthetic considerations in implant dentistry. Regarding the aesthetics in implant dentistry, as a periodontist, we're more focusing on the soft tissue way. And of course, people regarding the aesthetics into pink aesthetics versus white aesthetics. So people always look at pink regarding pink as the soft tissue only, but actually it's not. It's not only the soft tissue matters. You gotta look into it. It's everything underneath the soft tissue. So the pink aesthetics is not only the soft tissue itself, it's also regarding the bone, implant position, and of course, soft tissue itself. And for the white aesthetics, the important thing is about emergence profile, how to build up a good emergence profile for aesthetics, and also the porcelain aesthetics for the final work. So what aesthetic reconstruction do we consider in implant dentistry? That's a question we always have. And then we want to think about what's the key elements for aesthetics. So for aesthetic implant placement, there are a few elements I would like to talk about before we heading to the cases and also the clinical works. The elements I would like to point out is first, of course, the alveolar dimension, bone dimension, implant position angulation. Third one, soft tissue volume, emergence profile, and porcelain aesthetics. So those are key elements for implant aesthetics. Let's talk about the bone dimension first. As I said, I would like to point out the bone is the foundation. It's very important for aesthetics. And if we work on implants for the bone situation like this, we'll never get aesthetics without pink porcelain or any other type of artificial work to amend the soft tissue deficiency and bone deficiency. But if we change that situation, the compromised situation, into the good bone, then that's a good foundation we can begin with. The very important concept is peri-implant bone may undergo bone resorption, either physiologically or pathologically, and both happens in implant dentistry. So regarding the bone remodeling around implants, there are articles for the past decades that we can follow from the horizontal dimension, horizontal component, bilateral width, and we consider we need to have good bone, a certain dimension on the buccal in order to have good aesthetics. A lot of people point out it can be from 1 millimeter to 2 millimeters or to 4 millimeters. And for the bone resorption vertically, there are a lot of articles try to figure out what the dimension we would have for the bone remodeling around implants. It's sometimes it's between for the platform match implant can be up to 1.5 to 2 millimeters, but for platform switch implant, it could be as little as 0.6 horizontally and 0.62 vertically. And of course, so we come to a good idea that we need to have certain bone dimension to support the implant and also to keep the bone stable. In general, we need at least 1.5 millimeters of the a bone around implants. That's called a critical peri-implant bone wall thickness. So peri-implant bone stability equals to peri-implant soft tissue stability. Why? Because the soft tissue is actually supported by the underlying bone. So if we don't have good bone around implants, the idea is that if we could increase the soft tissue volume, of course, we can also add some volume for the aesthetics. And of course, we can build up the bone. That's the foundation. But at the same time, we're thinking about bone and soft tissue. We could also add some soft tissue for that purpose. Regarding implant position, the implant placement should be followed as a three-dimensional implant placement that was proposed by Boozer year 2004. But we need to be careful about those the three-dimensional implant placement, because they're one dimension that is very important, and also maybe ignore, or or some people may not pay much attention to. That's about implant angulation. The implant angulation should be follow the protocol, like ideal implant position should be the implant direction all the way to the incisal edge or through the cingulum. Anything between incisal edge and cingulum could be ideal position, good position for implant aesthetics. However, for certain instance that we will not be able to place implant at that prompt position, then we should try to avoid not too far flay out of our implant position. In general, within 15 degrees of the position, flaying out position, that could be manageable. So what about the three-dimensional implant placement? Let's talk about apical coronal direction. Well, there are a lot of dimensions being proposed, but now in general, we know that if we are using the platform match implant, not the best, and pumped implant position should be, apical coronal should be 2 to 3 millimeters away from the future CJ or the future gingival margin. However, if we are using the platform switch implant, that dimension could add it a little bit. So the dimension can be 3 to 4 millimeters. But of course, nowadays, a lot of people try to push up a little bit more because we need more running room for the aesthetics, for the emergent profile. But in general, for the platform switch conical connection implants, we now come to a very good result with implant placed 3 to 4 millimeters apical to the CJ or the future gingival margin. That could end up with good dimension for emergent profile, at the same time for good aesthetics. But not only the apical coronal direction, buccal direction also matters. For anything located in a aesthetic zone, we don't want our implant to place at the buccal position. We want at least in the middle, or better for the palatal position. And for angulation-wise, the ideal angulation, as I mentioned about, should be from cingulum to the incisal edge. Anything between that could be manageable very well. But if sometimes we don't get to that good angulation, we don't get a proper implant position or angulation. Well, in general, palatally positioning implant end up with that we say is a rigid lapping type of prosthesis, but in aesthetically, that is a very good reason. That would come up with a good result aesthetically. But if we place implant off axially, and as I mentioned, within 15 degree of the implant position with a buccal version, that could be manageable with like angle abutment or other type of abutment correction. So the key points about the bone and implant position, bone width and implant position are two factors that may affect each other. For example, if we don't have good bone, good dimension of the bone, we cannot have at least 1 or 1.5 millimeter on the buccal, then we should place our implant a little bit palatally, so giving some more room for the profile, and also for giving some room for the soft tissue. So bone width and implant position can affect each other in this way. If a buccal bone is thin, palatal cingulate position will compensate the bone. However, if we have a very thick buccal or crescent bone, then the implant placement could be relatively easy because we can have better bone to support our soft tissue. So if the bone is thick enough, of axial implant placement may be tolerable, because that in that way the bone will support the soft tissue and giving the appearance that we'll say aesthetically. And that's a reason why we want to have a good bone on the buccal, or we should place the implant carefully with the good position and angulation. What about the soft tissue volume? The soft tissue volume is another issue. Like in general, like Dr. Kahn, Joseph Kahn, year 2010 published an article that measured the mean gingival thickness for the implant site. In general, it's about 1.6 millimeters in average. So that was measured about 2 millimeter apical to the gingival margin. With that dimension, it's very relatively thin, because we always told that we want to have good thickness of the soft tissue for the implant aesthetics. And how thick is the thickness? At this first, we want to have a good volume, and also we want to mask the color from the abutment or the implant as metal. So the other thing we will consider the soft tissue volume is about the soft tissue volume would affect the bone stability. That there are a lot of articles being proposed and also talk about this issue. Back in 1996, the crescent bone resorption they found the crescent bone resorption in thin mucosa, and Thompson, and of course later on Thomas, they will point out that we need to have certain thickness of the soft tissue that can protect the underlying bone for the peri-implant bone stability. And of course, we need the volume of the soft tissue for the color masking, either to cover the zirconia abutment or cover the titanium abutment. And we need 2 to 3 millimeter of the soft tissue thickness in order to have a good color masking. That's a reason why, in general, most of people have the implant in a aesthetic zone without any soft tissue management or any intervention to increase the volume. Then we only have 1 millimeter of soft tissue in general. That is not enough. So we need to increase the soft tissue volume. On the contrary, if we have enough soft tissue thickness, of course, we don't need to build up or to increase the soft tissue volume for this purpose. So the soft tissue profile actually regarding the interdental papilla, we have Turner's article back in 2003 point out that the papilla between natural teeth and implant actually was infected by the bone between the implant and the natural teeth. However, if we have two implants right next to each other, the dimension actually is smaller than the implant next to a natural teeth. So anything that with a papilla between two implants, adjacent implants, actually will be smaller, as small to 3.4 millimeter in height. However, with implant to the natural teeth, it could be 4.5 or to 5 millimeters. 5 millimeter by Dr. Tano, 4.5 by other authors. And of course, we can use a punctate to increase the possibility of the soft tissue volume and to build up, to mimic our natural looking of the papilla. So when do we need to do the soft tissue grafting for aesthetics? That's the a very good question. In my opinion, first, if we have any soft tissue deficiency to begin with, then we do need soft tissue. Like the patient, the case with recession, and we need to place the implant on that tooth. Okay, and second of all is not sufficient jumping gap or buccal play whenever we extract the tooth, and because the jumping gap is very small, so we need extra soft tissue for further protection and further volume. The third, to compensate the bone resorption or anticipating any future bone resorption that could occur, so we need to amend that with a soft tissue. And the fourth one, of course, a patient with a very thin buccal or crest of soft tissue, then we need to increase the volume. We need to have around 3 meters in height, especially for aesthetics. And of course, if anything that start with a concave buccal soft tissue profile, then we need to increase the volume for aesthetics. What about emergence profile and porcelain aesthetics? It's all about three-dimensional emergence profile. If you're looking at the current article, 2001, that if an implant placed promptly, then would have enough running room, and also we have pumped room for emergence profile and to build up good emergence profile. On the contrary, if we don't place implant well at the wrong position, wrong angulation, then we end up with very small room or tolerance for the aesthetics. So those are examples that those implant were placed, and we have good angulation, and also we have good room, and also the implant were placed in the center, and good running room for aesthetics. And this is another example, two examples for one screw retain and one cement retain prosthesis. So the other concept is about the EBC zones as the aesthetical biological contour concept for emergence profile. I won't spend much time on this because this is all related to how to build up the emergence profile. In general, we need a certain dimension of the soft tissue for peri-implant bone stability, and that dimension was considered between 1 to 1.5 for the crest of bone stability. And of course, we have the certain dimension for the soft tissue to occupy this area, and that's considered for the either connective tissue or junctional epithelium, and this is biological boundary area. And then we come to the how to build up the profile. At the end, it's a contouring. So we have about 1 millimeter for the aesthetic conditioning, and to condition the emergence profile to the end to the certain dimension for aesthetics. So this is concept for the emergence profile. That means that we need certain dimension and rounding rooms for a good emergence profile. So this EBC zone first for stability and for soft tissue and for contouring. This in general, stability, soft tissue, contouring. So there was someone to try to compare the article by Zhu 2010 and also the current EBC zone. Basically, they're pretty much the same. There's all about we need certain zone for the stability and the zone for emergent profile. And of course, for emergent profile buildup, nowadays we know if a flat and wide or small angle emergent profile, that will end up with a bone remodeling resorption. And this is a study try to figure out a flat, relatively flat and wide healing abutment would also affect the bone stability. And of course, we now come to an agreement about the emergent profile should be a degree that it's more than 30 degree because we're giving some running room for the soft tissue. And also that soft tissue would keep the bone stable. And the last step would be prosthetic aesthetics, that we need a very top-notch lab technician for fabricating good porcelain work. So how to manage implants in the aesthetic zone? I would like to propose a treatment guide for the audience. First, we need to make decisions. The top priority, bone is the foundation. And then we need to keep in mind implant position, angulation would affect the bone in certain way. So the implant should be placed in the right angulation and right position. And third one, we need to consider if we need more soft tissue or we don't need further soft tissue. And soft tissue volume is also a key element for aesthetics. And the decision on emergence profile, we need to tune the emergence profile from the implant to tune up to find definitive crown. So we need that knowledge and also the rooms to build up the profile. At the end, we might need zirconia abutment to help out for aesthetics, and of course the good porcelain fabrication. Let's give this example. I would take this example to show how I deal with the cases in the aesthetic zone for the reconstruction. So on the left side, that's the case initial and the end, and of course patient hasn't decided to have the root coverage on this lateral incisor. That's why I would leave that way. So you can appreciate that we start with a very compromised aesthetics and end up with relatively aesthetic result. And of course, this the reconstruction, the before and after. So we reconstruct the aesthetic zone and also given a good a vertical support. And this is before and it's after. And 2 implants with the pontic development for aesthetics. And this is the CAT came before the procedure initial. So the patient have the certain bone loss and buccal dehiscence and some lingual bone loss as well. And also this one, the buccal bone loss all the way to the apex. So we have the situation, those 2 teeth with buccal bone loss and then bone loss all the way. And for the edentulous area, certain bone loss also noticed. So in order to build up the aesthetics, we extract those two teeth. There's a buccal and lingual bone loss, and there's buccal dehiscence all the way to the apex. And of course, we reflect the flap, and implant will place in a correct prompt position. And we want to keep the implant at the correct position with a three-dimensional implant placement protocol. Apical coronally, we would like to have the implant platform 3 to 4 millimeter away from the future CJ or future ginger margin for aesthetics. And also anything that the implant threads may expose, they would have to cover with a bone. So we build up the bone to protect the deficiency, and also we build up the pontic area, and also this one. So this is the implant being placed and grafted with a bone graft, covered with the resolved membrane as an R6+, relatively long-lasting collagen membrane and primary closure. This is a week after. So you can appreciate the implant placed in a relatively correct position from the final position. At the second stage, we found that those two implants being covered by the newly regenerated bone. So we have to dig out the implants in order to uncover them. And then also the soft tissue wise, we not only have good bone, we have good soft tissue to begin with in this instance. So we have about 3 millimeter of the soft tissue in thickness. And for the implant supported bridge, we would like to have a pontic area to mimic the natural teeth looking. So this is the definitive result without any soft tissue grafting, because at the time, patient didn't want to have soft tissue grafting to build up a more volume, and she's okay with the soft tissue and also with the appearance. So we finished the case by this. So you can appreciate that we have very good pontic area, and we have implant placed in a correct position, and we have good emergence profile and good running room for the aesthetics, and basically follow the protocol, follow the emergent profile, how we build it up. We straight up, we have space for the bone stability, and we have space for the soft tissue volume, and then we mold the soft tissue to mimic our natural looking. So this is the result, and the patient smile. So we kind of achieve very good aesthetic result by follow the protocol: bone, implant position, soft tissue. So the tips for that, we have dehiscence bone type. So we need to build a bone for aesthetics, that which is required and important. Proper implant position is the ticket to aesthetics. We have to keep in mind. And soft tissue wise, the soft tissue, if we have enough soft tissue, then we can tune up the aesthetics, and also we protect the bone. And of course, we would have good emergence profile build up, and then posing aesthetics for this matter. So this was the example telling us how I deal with the aesthetic issues step by step. So let's begin with the elements of soft tissue reconstruction only. We need soft tissue for implant aesthetics, especially we need certain quantity and quality whenever we have cases that this type. So soft tissue management around implants is important, and also is a very hot topic. Essentially, we can use the soft tissue augment the buccal side, crestal side, and also we try to gain the keratine tissue for aesthetics. Let's talk about buccal crestal augmentation with soft tissue. And apparently the case that we're talking about will be good bone, maybe compromised implant position, or compromised bone, but it could be managed with a soft tissue. So we use the Herzl technique or Lawrence Island technique for the donor side, and the pouch technique for the recipient side. This is the original pouch technique and the modified pouch technique. And this is the donor side, the Herzl one incision, single incision technique. So for this particular case, patient came in with this problem. Patient had the implant placed, and however, when the dentist given her the provisional, then she got freaked out because that was solely over her imagination, that she couldn't take that the result that would have the metal showed up buccally, even though the dentist told her that the metal will be changed to zirconia at the end. But then if you look at two centrals, they will never look identical, never look harmony. So patient came to my office for the assistant. She came in, tried to have the implant removed and getting a new one. But when I look at this patient, the X-ray, well, this is the cone beam CT taken after I restore everything. So I didn't have the initial cone beam CT taken. When we look at that, the implant was placed off axial. It was placed off axially, and so not in I would say prompt position. It was flay out, but the flay out actually is a little bit over 15 degree. But we were lucky. The patient was lucky to have good bone on the buccal, so that can overcome the problem of the flaying out implants. Okay. So when I looked at would have good bone on the buccal, the implant angulation was a little bit compromised, but then with the soft tissue, we can try to we can amend that deficiency. So we don't need to remove the implant for aesthetics, but we need to build up more bone. So if you look at the emergency profile, it's almost straight up to the contour, because we certainly didn't have room for the emergency profile. So I mean, we have room for emergency profile, but we didn't have enough room for buccal pushing up the buccal soft tissue. So we want to keep the profile straight up. So what I did, I removed the provisional, and at the same time, you look at the implant position. Well, it was in the center, and then it was angled. So I removed the angle, the abutment, and then I just left the soft tissue healed up to heal up by itself. Because when healed up by itself, then I gained some soft tissue to work with. In this manner, then I could just take the connective tissue from the palate, and by using the pouch technique, I grafted the soft tissue buccally and crestally, and suture it up, submerge the connective tissue. The reason why I want to submerge it, because I have to increase the soft tissue on the buccal vertically and horizontally, both of them. So with this manner, I could manage the soft tissue well, and also to maximize the buildup of the soft tissue vertically. And then in 3 months, I would have enough soft tissue, so I could I did the uncover procedure, uncover it, and this is the definitive prosthesis done. Unfortunately, the patient didn't want to have this existing crown replaced, so the new 3 crowns have to compromise the appearance by mimic this existing crown. But in general, the result was great, and then the patient was thrilled, and she was so happy about it. And with a very little, just the soft tissue surgery, and we could end up with a very good aesthetic result. So this is before and after. And this is the after, and the patient was happy about it. And before, after. And this is the the follow-up 3.5 years after the procedure. We still have very good soft tissue around the implant, and also very good aesthetic looking. So for this particular case, there were bone on the buccal that tells us there's a good foundation for aesthetics. That's the first one, which is good. And the implant was acceptable implant position. It was flare out, but not too much toward that degree that we couldn't manage it. So even though it's not prompt, but it is acceptable. Because it's acceptable angulation that allow us to manage that problem. And patient, of course, didn't have enough connective tissue to begin with, so we need to build up the soft tissue for that quality as well. And emergence profile, we need to leave a lot of room for soft tissue. So we have very straight up emergence profile. And of course, we find a top-notch technician for the aesthetics. So that's first the soft tissue problem we deal with. And I would like to show you this case for the buccal only. If anything that we have soft tissue problem on the buccal, then we can just augment the soft tissue on the buccal side. We use a modified tunneling technique. And I also use a laser deepithelializing technique. This technique was developed by me and Dr. Nevins, Dr. Kim from Harvard School of Dental Medicine. And then that was published in 2018. We use a laser to deepithelialize the free graft in order to get the very good connective tissue. With similar to Zucchini technique, use a blade to take out the epithelium. But instead of blade, we use laser to take out the epithelium intraorally. So this is the case. Patient came in with metal showed up on this implant, and also the fracture central. So we first to treat the central, the fracture central incisor with a crown, and then fabricate new crown. But for this particular implant, well, this implant, there was no bone on the buccal. You can notice that. And the implant was positioned not quite in a pump position, but it is manageable. It's incisor edge, so better than flare out. But then we have a problem here is because no bone on the buccal at all. So what we want to do, we want to use a very good, very thick connective tissue to cover the threads on the buccal. So giving a very good soft tissue protection. And with this manner, we harvest the connective tissue by using the laser deepithelializing technique, given that a very good quality of connective tissue will be obtained. And then there's a modified tunneling technique. So we insert this piece of connective tissue to this implant and suture it up. And this is before and after. And you can see the follow-up. The patient were undergone the ortho treatment. And you can see the tissue here, very good volume of soft tissue and getting keratinized. So this is follow-up for 2.5 years. You can appreciate that a very good soft tissue on this. And of course, this center was fracture central. We did connecting and build it up. So tips for this case, even though we have no bone on the buccal, and we can count on the soft tissue attachment to cover the exposed threads. And the key is acceptable implant position, so we have some room for soft tissue attachment. And of course, the patient have certain recession to begin with, so we replace that with a very dense connective tissue that could have very good soft tissue to cover the area. And imaging profile and posing aesthetics, and of course, we just follow the protocol. So even with that's the very compromised situation, we were able to obtain this result. So that's all about soft tissue. So soft tissue, the matter is that, do we have enough soft tissue to begin with, or do we need more soft tissue? And decision making, as I mentioned before, those are there are scenarios that we need extra soft tissue to amend either bone problem or implant position problem. What about hard tissue reconstruction? The hard tissue reconstruction, we are looking at the foundation. So we need ridge augmentation, or we can use a simultaneous or stage approach, resorbable versus non-resorbable membrane. So that this given this case as an example, simultaneous stage approach, basically it doesn't matter. So as long as we could get very good bone around the implants, it doesn't matter whether it's a simultaneous or a stage approach. Both of them could achieve good aesthetics if we could get good result for bone. So this patient came in with those front teeth being extracted, and of course, there's some bone destruction, bone loss, resorption undergoing. Is ongoing bone resorption. So when we open it up, we found there are some spots that we could place implants, even though it's the bone missing on the buccal. But because it's just current extraction site, so we can do the early augmentation concept to build up the bone. But this area is a long lost area, been edenturism for a long time, for decades. So we need to do it differently. So I use non-resorb membrane for this long loss area, and use resorb membrane to cover the current extraction site. So this is how I want the bone on the buccal. Follow protocol, we need at least 1.5 millimeter bone on the buccal. Better 2 millimeter for aesthetics, of course. The more the better. So we suture it up. In 7 months, when we open up, yes, we have good bone on those implants, and also we have very good bone for this stage approach. So I was able to place implant here with a very good bone on the buccal, and did uncover procedure for transitional stage. We were supposed to do the connective tissue graft for this particular case, but the patient didn't want it at that time, so we didn't do it, and we'll skip that part. And this is the final, the definitive, the final results. Even though it's not ideal, because we need more soft tissue, but then even this, we did have enough good bone, so we could compensate the soft tissue deficiency. So this is the results. We have very good bone on the buccal, and it's before and after. And 4-year follow-up, we still have very good aesthetics result. So the tips for this case: building on the bone, either resorbable membrane or non-resorbable membrane. It depends on what scenario, what situation we are looking at. If a long loss membrane, long loss area, very thin bone, of course, non-resorbable membrane is better to keep up the space and also hold up the space, and the space making the property is better. Resorbable membrane working out really well for a fast healing site, And of course, we need optimal implant position is a must for aesthetics. And post-bone augmentation, as I mentioned, we didn't need the soft tissue augmentation for this particular case, but then a patient didn't want have the soft tissue procedure wise, so we skip. But even though we skip the soft tissue volume, we still have good bone, so that could give us good aesthetic result. And emergence profile is a framework for aesthetics for sure. So what about the hard and soft tissue reconstruction? In most of the time we have problem dealing with patients with both hard and soft tissue issues. So this is a case I would like to mention about the immediate approach and connective tissue graft. I use a double papilla technique and then one single incision technique for the donor side. So when patient came in with this problem, a big recession, fractured tooth with a resection all the way, and then there's a probing depth all the way to the apex. So we have resection to begin with. That means that we need to build up the soft tissue. And of course, we have dehiscence bone, so we need to build up the bone. So bone and soft tissue has to be built up for this particular case, for sure. But the scenario-wise, it's a very compromised situation. So because the bone architecture here is very challenging. So when I extract the tooth, there were buccal plate missing completely, and also some lingual plate missing as well. And then implant was placed according to the three-dimensional implant placement protocol, 3 meters away from the future CJ or future soft tissue margin. Implant was placed, and bone grafting membrane cover. And at the same time, I took connective tissue from the palate and grafted with a technique. It's a double papilla technique. So we suture both sides of the papilla as one flap and close it up as primarily. And in 6 months, we are able to do our second stage and start molding the soft tissue. And this is the before and the final result. And this is a 5-year follow-up and 8-year follow-up. Well, in the meantime, I also placed one additional implant here for the lateral because of fracture issue on this lateral incisor as well. But in 8 years, you can see we still have very good profile in soft tissue and aesthetics for this particular case. And then 13 years, in 13 years, we still keep that dimension very well and symmetrical. Very good result for the aesthetics. And this is the bone, the X-ray. So for this particular case, please begin with no buccal bone. So we need to build up the bone, and we need to have good soft tissue to protect the bone. So we need bone and soft tissue for this type of scenario. And of course, because the bone architecture was not good, so it's a compromising position. So we want to keep the angulation less than 15 degrees. At the same time, we need more bone and more soft tissue to compensate this particular implant position issue. And soft tissue, of course, dense and thicker soft tissue is always good for this scenario. And emergence profile, we need some room for soft tissue and getting good porcelain lab work for this aesthetics. There was another case I would like to talk about. This I use different technique, a toning technique. For this particular case, patient had the fracture breach, fractures central and lateral with a existing breach. So you can see all the front teeth porcelain were, because the fractured tooth, we remove the existing breach, and is a hopeless. Very buccal plate missing, lingual plate missing a little bit, and buccal plate missing for this central. So for the lateral and the central, both of them has bone dehiscence, soft tissue dehiscence. So we need both bone and soft tissue augmentation to meet our first requirement, bone and soft tissue. So this is before that there was the existing prosthesis and been removed. So we have immediate implant being treatment planted. Those two teeth were extracted, and implant were placed, leaving good jumping gap for grafting. And this is buccal plate the fenestration. So I reflect this flap to build to augment or to bone grafting the fenestration and augment the implant site and membrane cover. And at the same time, I took connective tissue from the palate. This is Zucchetti technique. So I use a 15C blade, take out the epithelium, leaving good connective tissue, cover it up. This is the result. Implant was placed, and we have implant placed, good bone augmentation, and good soft tissue augmentation. So after those procedures, we build up the bone and soft tissue. So it's time we can uncover those two implants. And of course, the aesthetics on the way. We have very good soft tissue implant position, running room for aesthetics. And we have implant supported bridge with a punctate development for aesthetics. So this is the final result. The definitive. We have good running room and soft tissue and profile, and good bone on the buccal, good bone on the buccal. You can appreciate it. So this is before and after. So if you look at this particular case, that everything restored before and after, we also change the appearance of the prosthesis. So not only we correct the initial problem, we enhance the aesthetics by correcting the bone soft tissue problem and good restoration. That could guarantee a very good aesthetic result. So the tips for this patient, this type of defect, dehiscence bone, we need to build the bone for aesthetics, and we need to place an implant in optimal implant position. We can compensate the bone issue. And of course, we need a very good soft tissue, very dense and thick soft tissue to overcome or to compensate the bone problem as well. And of course, we have good room for emergence profile and imitate the contralateral teeth. So let's get to the compromised bone situation that is a major issue. So whenever we have very compromised bone or issues, we build up the bone, place implant in the right position, and to maintain proper soft tissue volume or to bulk up the soft tissue. With those three, bone, angle, implant position, soft tissue, basically, we do solve the problem. And of course, we need a very good prosthetic work. So massive vertical ridge augmentation for a very compromised situation we facing that. So for this particular case, a 15-year-old lady came to my office with falling implants and an infected implants. So I treat the urgent problem first, and then I remove those failing implants, remove those implants, and leaving a very massive bone destruction. And we let the soft tissue heal up, and we have this problem. No room for implant placement. So we could, I put a tendon screw, bone grafting, and the bone loss to the ideal position is more than 11. Actually, the deepest part is getting to the 14 millimeters, 15 millimeters. So tendon screw, bone graft, and non-resolved membrane, and suture it up. So this is the result of the bone augmentation. And then I asked the orthodontics to intrude the mandibular anterior dentition, because those dentitions actually will have the compensation syndrome. So we need orthodontics to intrude those anterior dentition. So now we have good rooms for the aesthetic zone, and very good bone will build up, and it's time to place implant. So with very good bone dimension, we were able to place implant at a very correct position, angulation, and good results. And for this particular case, I did the strip regional graft. I call it apical regional graft back in the time. That was that time I called it as a boring technique. So I use a strip of free graft as a border around it, that area. In this case, I will try to get a better color matching. So this is how much bone we achieved, and this is the result. But the patient didn't like the appearance of this prosthetics, so I did another one. This is option 1, option 2, and option 3. Patient liked the option 3 because she liked to have a very prominent central incisor. So this is the definitive results she really she preferred to have. So this is 7-year follow-up. Even though there was some remodeling happen, but we still have very good implant and soft tissue appearance. The next case is the vertical ridge augmentation. Of course, some soft tissue issues as well. 36 years old lady came in with this massive destruction for the aesthetic zone. How to get to that part, the aesthetic looking? So first of all, we need to solve the bone problem, soft tissue problem, and get to that part, the aesthetic. So we remove the failing implants, and those failing implants actually been removed, leaving a very massive bone destruction. The deepest part is about 15 millimeters, and this is about 11 in center. So I use a tendon screw technique and bone grafting, non-resolved membrane, and cover it, primary closure. And the results. So when I open it up, we have good bone. So 2 implants were placed, and I grafted again to protect the newly regenerated bone. And then I tried, unlike the first case, I did a free graft type of technique only. This particular case, I harvest connective tissue from the palate and deepithelialize it as a connective tissue graft, and graft it to the recipient side, which is on the crescent and the buccal. So we have enough volume of the soft tissue in the aesthetic zone. Then it's time to build up the current tissue. Back in the past, I used to do connective tissue graft to build a volume, and then free graft to build up a current tissue. And this one, particularly for the aesthetic zone, I use the epithelialized free graft, try to get better color matching. Even though sometimes it works, sometimes it doesn't. But in general, the color will be a little bit better than the epithelialized one. So for this case, this is before and after. Even though it's a massive bone destruction, we have good room implant and good room for aesthetics. And then we have a good imaging profile. Then we can build up this for reconstruct the aesthetic zone. And patient was happy about it. So another case, patient came in with this problem, been treated with bone augmentation, but failing a few times and was referred to my office. The first thing is to build a bone and the soft tissue and place implant and then prosthesis. So we just follow protocol. I refer the patient back to his the referral dentist to have the membrane and removed. So once removed, the soft tissue heal faster. And then we just wait, getting more soft tissue so we can build up the bone. But we have the problem here, the canine, the upper left canine has very thin tissue on the buccal and no canal tissue. So we need to build up the soft tissue there in order in order to have the bone augmentation and good bone augmentation on this area, because with a very compromised soft tissue, it's very difficult to get the primary closure. So I use connect tissue and wrap it around technique and build up the soft tissue on the canine and let it heal up for 4 months. And that's the time I can build up the bone. So I use tendon screw, bone graft, non-resolved membrane, and cover everything up. And just let it heal up for a while. So this patient, I wait for 18 months. Patient come back. We have very certainly good bone. So it's not a problem. We can place 2 implants with this scenarios before and after. We have very good bone. So I placed 2 implants and close it up. But this particular patient didn't want to have connective tissue graft. She didn't want 2 surgeries for the soft tissue. So instead of 2, I just did 1 as the epithelialized free graft because connective tissue is more important for maintaining implant health. And of course, soft tissue volume is for peri-implant stability as well. But then because the patient willing, she didn't want. So instead of 2 soft tissue procedure, I did 1. This is donor side. And this is the final results, the definitive results. So we have solved the problem for bone, soft tissue, and implants, and getting better results. So the last case for the massive bone augmentation, I would like to share with you. This particular case, patient came in with a severe periodontal disease and failing implants and hopeless from canine to canine. So those teeth were extracted and like the soft tissue healed up, just that those cases I did. And I give them the patient at the Marin Bridge as a transitional stage. So in 2 months after extraction, soft tissue healed pretty much well, then leaving the very huge defect here. So what I did, just like those case, massive destruction case, I did it a little bit different for the soft tissue, but for the bone here, I use both resolvable membrane and non-resolved membrane. So the incision here, crescent incision, and decorticate and bone grafting, I use tendon screw, 10 out the space, and I use 2 types of membrane, non-resolvable and resolved membrane. They worked up together because I have to treat the perio problem of 2 premolars for periodontal regeneration, and to keep the space, maintain the space for aesthetics, and build up the bone for implant and also for aesthetics as well. So this is a very difficult scenario that we're looking at. So not only the bone augmentation GBR, but we also need to consider GTR or periodontal regeneration for the adjacent teeth, those 2 premolars, which has both of them had the intrabony defect, periodontal intrabony defect, mesially. So those are the bone augmentation done, and this is showing the releasing and showing membrane cover. So just like those cases I did, build up the bone is the top priority. And after we have good bone, so we can place implant at right and prompt position. And later on, we'll consider soft tissue to build up good soft tissue to protect the bone, and then to have good aesthetic look. So with this kind of thinking process, we can make things easier, and we can have very good treatment planning and decision making for certain type of patients. Always thinking about bone, implant position, soft tissue. So whenever, and then we should show it up as a primary closure. Okay. And as a result, the bone augmentation. So with two non-resolved membrane and then resolved membrane. So we close it up. And here. With this scenario, now we're dealing with a soft tissue problem. And also the patient, because she thought that because of breach that you know, had given her hard time maintain oral hygiene and keep those teeth healthy. So she didn't want any type of bridge work. So instead of implant supported bridge, which were what I have been doing most of the time, I gave this patient the option of individual implants. So after implant removed in 10 months, we have very, very good bone. So we were able to change this defect, periodontal, and intrabony defects into very good bone scenario. So we're able to place 6 implants in a very ideal position. And I augment the bone again to protect the newly regenerated bone. So this is the result. But for this case, I did it a little bit differently. This is a new protocol. I would like to treat those this cases with the post augmentation soft tissue management. So what I did, I used a connective tissue, of course, harvest from the palate and deepithelialize them, and grab them both buccal and coronally to gain the soft tissue on the crest and on the buccal, and suture it up. Okay, this is how I harvest the graft from the palate and how I suture it up to stop the bleeding. So you can appreciate that I use the laser to deepithelialize the graft. So then I can harvest them as a connective tissue graft. So this is harvesting hemostasis. And in 2 months, I have good volume. But then if you look at it, we now have new problem of the carotid tissue. So it's not done yet. We need to get good carotid tissue. So what I did differently nowadays, I use laser to deepithelialize the mucosa. And when I deepithelialize them and then did a second stage uncovering procedure, then I could achieve, to expose the underlying connective tissue, which is the genotype would determine the phenotype. So at the end of the day, I would get the carotid tissue to increase the carotid tissue. So this is what I did, uncover, and also I use laser to deepithelialize the area and also to make the incision. Okay. So in certain way, I cover the connective tissue graft just like a pouch technique, but then I let it healed up. Then I use a deepithelialize technique to expose the underlying connective tissue, and also, of course, to uncover the implants. So this is a provisional crowns after the uncovered procedure. So this is result before and provisional. We are now in the stage of the final restoration, definitive one, because the pandemic, so everything been delayed. Now we're trying to get the definitive restoration for this particular case. So the tips for this being patient: no bone means no aesthetics. So we need to build the bone. There's a foundation for aesthetics. And prompt implant position is a must. So it's very important to use whatever it takes, the guide or navigation, guided surgery, to have a good implant position. And soft tissue, we need both volume and keratine tissue. So volume, soft, and keratine tissue, both of them very important. An emergent profile, we just mimic the natural dentition. Okay. So the take-home message for today's lecture, and aesthetic dentistry is something that requires multidisciplinary approach to build up or to modify the foundation of the alveolar bone and gingival soft tissue. They're both essential for achieving implant aesthetics. So in other words, bone, implant position, soft tissue, prosthetic aesthetics, there are 4 keys to the aesthetics reconstruction. And of course, among them, bone is the top priority. So bone, implant position, soft tissue, in that are surgically measurement, they determine most of the aesthetic outcomes. I can give an aesthetic equation: bone plus soft tissue plus implant position plus emergent profile equals aesthetics. So I would like to share with you my thoughts. Even though implant aesthetics is very difficult and very challenging most of the time, but I would like to propose this approach and protocol that we solve the bone issue, implant position issue, soft tissue problem, and emergence profile, which is posing aesthetics. The prosthetic work are very important to get the very final result and aesthetics. So I would like to share with you this equation as it is a take-home message for all of you. And of course, thank you for your attention. Because the time issue, I have post some videos on YouTube. You can follow on the YouTube, and those are free videos you can look at. And if you want to reach out to me any questions, you're more than welcome. Reach out to me through email, Facebook, Instagram, WeChat, and I'll be happy to answer the questions and to for further sharing. And again, thank you for your attention, and thank Academy for the invitation, and see you soon. Hopefully we can have certain lecturing in the future in person. Thank you. Bye.